So good evening, everyone, and good morning and good afternoon to people joining us from different parts of the world. It's a pleasure to welcome you all to the second series on peritoneal surface malignancies. And this is our third webinar on PMP, which just emphasizes the importance of this topic for us. This time, we are just focusing on recurrent PMP and surgical strategies for its management. Now that we've learned enough about dealing with PMP, advanced PMP, we need to know how to manage recurrence as well. And we have some of the best speakers, the most experienced speakers in the world on this, the team from Basingstoke PMI. To begin with the first session, I'll invite the moderators, Dr. Deepti Mishra and Dr. Robin Kambudurai.
Hi, thanks, Dr. Aditi. So very happy to be on a webinar with my old friend Sanjeev. So Sanjeev and I trained together at CMC Ludhiana till we went our separate ways, and he has obviously gone on to do very well and be a consultant at Basingstoke, and well, can't wait to hear from him. Start, Sanjeev.
Should I share my screen?
Yep.
Share.
Is it just about right? Can you hear me?
Yeah, we can hear.
Are we good to go then?
Yeah, go ahead, start.
Right. So good evening, ladies and gentlemen. I would like to thank Dr. Bhatt and the organizing committee of INDESPO for giving me this opportunity to present to you all. So pseudomyxoma peritoni, as we well know, is rare, and in more than 90% of cases, the primary is the appendix. Cytoreduction surgery in HIPEC, which was first described by Spratt in 1980 and then popularized by Sugar Baker, became the reference treatment option despite no randomized data because of the excellent results achieved from this multimodality treatment. Nevertheless, recurrences still occur, and there is a failure rate ranging between 25 to 44%. Extraperitoneal sites of recurrence also occur, but their incidence and impact on the course of disease is not clearly understood. So I've divided my talk into the following subheadings: recurrence from incidental low-grade appendix tumors, recurrence from incidental high-grade appendix tumors, surveillance to detect recurrence after cytoreduction surgery and HIPEC and rationale, post-cytoreduction surgery recurrence management and outcomes, extraperitoneal recurrence, recurrent disease progression abdominal wall challenges, and how small bowel transplant came about in PMP, its rationale and criteria for selection. So when an appendicectomy is performed and the histology comes back as a low-grade appendiceal mucinous neoplasm, it is important to ascertain whether there was perforation, whether there was extraappendiceal mucin, or any extraappendiceal neoplastic cells, or both. A multi-institutional study in America published in the Annals of Surgical Oncology recently looked at the recurrence from this, and they identified 217 patients. They had a follow-up of approximately 52 months. They found that in the absence of perforation or extraappendiceal mucin or cells, peritoneal recurrence was extremely rare. When perforation was present, the risk of peritoneal recurrence was 15.2%. Majority of the recurrences occurred within 2 years. When there was perforation, extraappendiceal mucin, or extraappendiceal cells. Their literature review and pooled analysis revealed that the overall risk of peritoneal recurrence was highest when there were cells present. Literature review quotes a peritoneal recurrence of approximately 0.7% at a median follow-up of 54 months when there is no perforation. A study by the Netherlands Cancer Institute published in 2008 concluded that any appendiceal primary, regardless of perforation, progressed to PMP in 10% and in 20% if the disease was high grade. So perforation or not, there appears to be a risk of developing recurrent disease. So our follow-up is performed under two categories. When an appendix histology comes back as an incidental low-grade appendix primary. The first is when at appendicectomy, there's no visible peritoneal disease, and the second when there is localized visible peritoneal disease. In the first category, when there's no visible peritoneal disease, whether there's perforation, extracellular mucin, or cells, we follow the protocol with a 1, 3, 5, and 10-year surveillance. When there is localized disease visible, annual surveillance is followed up to 20 years. Even when there is microscopic involvement of the appendix margin on histology, but colonoscopy is clear, the same protocols are followed. The story is different for incidental high-grade appendix tumors. A recent study by the Peritoneal Surface Malignancy Treatment in Japan categorized patients into 4 groups based on histology and whether there was perforation. They found that when the histology was high grade and there was perforation, nearly half the patients had recurrent disease. And this was 25% when there was no perforation and disease was high grade. When appendix pathology is high grade, the significance of nodal involvement has been questioned. Sugarbaker, in his review published in 2017 of 299 patients who had complete cytoreduction, found lymph node involvement in 17% of patients. Further classification of high-grade tumors into well-differentiated, moderately differentiated, and poorly differentiated by evaluating the epithelial content of tumors revealed that poorly differentiated tumors were the most likely to metastasize to lymph nodes. Of note, out of the 299 patients, all of whom had complete cytoreduction, 247 of them had no histological evidence of lymph node disease. But yet, despite complete cytoreduction, their disease progressed and resulted in death in nearly half of these patients. So lymph node disease appears to play less of a role in determining overall survival in these patients. We looked at rates of peritoneal and nodal involvement in patients with high-grade disease without obvious metastatic disease in our study published in not long ago, probably 5 years ago. And we looked at patients from January 94 to September 2016. And all these patients did not have any clinical or radiological evidence of peritoneal disease and who had undergone cytoreduction surgery and HIPEC. Despite the retrospective limitations of the study, we found that half the patients had peritoneal involvement and 15% had lymph node involvement. Lymph node involvement was similar to what Sugarbaker had found. The median interval between appendicectomy and cytoreduction surgery in HIPEC was approximately 4 months. There were no perioperative 90-day mortality, and there was just 1.6% grade 3/4 complication. 17.7% had microscopic disease, despite nothing being seen at the time of surgery. Little over a third had peritoneal disease away from where the appendix lives. And if there was nodal involvement, majority of those patients had peritoneal disease. The Kaplan-Meier curves showed an 83.2% 5-year overall survival and a 76% 5-year disease-free survival for all these patients. Disease recurrence was seen in 11.3% patients, and some of these repeat cytoreduction surgery was possible. In a study of 1,000 patients published in 2016, 211 out of these 1,000 had high-grade appendix tumors with radiologically proven peritoneal disease. Complete cytoreduction was, however, possible in only a third of these patients. The 5-year disease-free survival for these patients who had complete cytoreduction was approximately 55%. So one can extrapolate from this disease-free survival and use this as rationale in favor of prophylactic cytoreduction surgery and HIPEC, where disease-free survival was 76%, as this may be definitive treatment for some. So in our unit, all patients referred with incidental high-grade appendix tumors after appendicectomy are offered prophylactic cytoreduction surgery and HIPEC to, if not cure, to improve disease-free survival. The surgery involves a radical right hemicolectomy, a right parietal peritonectomy, a radical greater mentectomy, and bilateral oophorectomy in women. Fertility options are considered in women who want children. Once complete cytoreduction surgery has been performed for patients who are referred with PMP, literature quotes a failure rate between 25 to 44%. This should be optimally picked up so that they can be optimally managed. Due to the rarity of PMP, there's little information on the duration, the methodology, or intensity of radiological follow-up, and there are no specific accepted international guidelines. When planning long-term surveillance, one has to also consider substantial healthcare cost, as well as the psychological impact on the patient, and by repeated CT, risk of cancer induction from the radiation. We analyzed our data from the first PMP case performed in 1994 until the end of February 2016. A little over 1,000 patients had undergone surgery, and 775 of them had had complete cytoreduction. Our cumulative experience with some patients with more than 20-year follow-up provided a unique opportunity to propose a recommendation on the intensity and duration of follow-up. Our previous standard surveillance protocol was annual CT with measurement of tumor markers. Histological grade did not influence the surveillance protocol previously, but given the now well-established differences in the outcomes between low-grade versus high-grade, overall survival and disease-free survival was separately looked at for the two groups in the study. The Kaplan-Meier plot on the right shows the overall survival, and the one on the left, the disease-free survival. This bar chart from the study shows the disease-free survival according to the histological differentiation over the first 10 years after complete cytoreduction surgery in HIPEC. Unsurprisingly, patients with high-grade mucinous appendix tumors, adenocarcinoma, or signet ring cell morphology had increased recurrence rates. We found, regardless of histological classification, majority of the recurrences manifest within 5 years. Occasionally, recurrences during the next 5 years, however, still do occur. This contrasts from colorectal cancer, where generally most recurrence occurs within 5 years after curative treatment. The 5-year disease-free survival for low-grade disease was 69% versus 26% for high-grade disease. And patients with high-grade PMP were seen to have a steep decline with a 60% decrease in disease-free survival over the first 3 years. Given disease-free survival for both low and high-grade PMP tends to stabilize at 6 years, albeit after patients with high-grade PMP suffering a steep initial decline in disease-free survival, our previous initial follow-up for high-grade disease was changed and made more intensive. Surveillance after 6 years gets spaced out to 8, 10, 11, 15, and 20 years. With regards to CT imaging during surveillance, we recommend that for optimal detection of peritoneal disease and its relationship to small bowel in particular, oral and IV contrast should be administered. Extraperitoneal recurrence for low-grade disease occasionally occur, but we felt that the pickup rate of additional CT chest on each occasion outweighed the risks of additional exposure to radiation for the whole low-grade PMP population. Once recurrence is confirmed, often managing these patients is a dilemma. Our retrospective cohort looked at patients treated with complete cytoreduction surgery from March 94 to December 2017. 37.5% of patients had disease recurrence. The median follow-up was 53 months, and majority of these patients were asymptomatic at the time of diagnosis. A third of these patients had redo cytoreduction surgery at a median of 9 months after diagnosis. And in 60% of these patients, cytoreduction was complete, but in nearly half of them, the disease recurred. The remainder had non-surgical management, which was wait or watch, or palliative chemotherapy. We found that the factors associated with early recurrence, defined as recurrence within 1 year, was high-grade tumor, signatoring cells, and raised tumor markers. Factors associated where repeat cytoreduction was less likely. These were high-grade disease again, early recurrence, and raised tumor markers. Factors that were associated where repeat cytoreduction was likely was when the disease was focal, the patients were symptomatic, and in younger patients. So in our cohort of patients who recurred and who had surgery, 86 had focal disease. 86% who had focal disease cytoreduction was complete, as opposed to 38% where the recurrent disease had been found to be widespread. The risk of having a new stoma at recurrent surgery was higher for patients with diffuse disease, and the majority of the end stomas after repeat cytoreduction were in patients who had maximal tumor debulking. Regarding extraperitoneal disease, we found 14 patients had gone on to develop interstitial liver and lung metastasis, and 10% experienced pleural disease. Histologic disease progression compared to initial pathology was noted in 11.7%. That is, PMP that had previously been low grade had become high grade. Those patients who recurred after redo complete cytoreduction surgery, nearly half underwent second redo surgery, and complete cytoreduction was achieved in approximately 75% of them. 2 of these patients then had third surgery for recurrence. So multiple redo operations are possible, but in a very selected few. At the end of follow-up, 12.1% in our cohort were disease-free. The overall survival for the cohort at 3, 5, and 10 years was 74, 57, and 36%. In subgroup analysis, for the patients who had complete cytoreduction, 5-year overall survival was better at 89.6% and a 10-year survival at 68.2%. Although these patients represent a highly selected group, the survival outcomes were similar to what has been noted in literature for patients who have primary complete cytoreduction. So repeat cytoreduction surgery, if complete, can improve survival. So in our unit, redo cytoreduction surgery is considered when disease is focal or limited, and complete cytoreduction is likely to be feasible. Or for symptoms where maximal tumor debulking is likely to be beneficial for patients willing to accept the potential of a permanent stoma. This is an example of a lady who was 36 at the time of presentation when she underwent a total abdominal hysterectomy and BSO, omentectomy, and appendicectomy. And this was in November 2018, when her histology revealed a well-differentiated mucinous adenocarcinoma of the appendix and high-grade mucinous carcinoma peritoni. She then had CAPOX chemotherapy from March to September 2019. She had complete cytoreduction surgery in Basingstoke in January 2020, where she had all peritonectomies and a right hemicolectomy. This was followed by second-line FOLFIRI treatment from April to December 2020. She then recurred, but her sites of disease on CT appeared limited. Her case was discussed with her treating oncologist, and we found that she had not quite tolerated her chemotherapy well and had required significant dose adjustments. And while she could be re-challenged, given that she was a little over a year since her last chemotherapy, her chemotherapy options were limited. So we then performed a diffusion-weighted MRI, which is our protocol to look for subtle disease and assess if repeat CRs is offered, whether complete cytoreduction is likely. This picked up further disease over the iliacs on the left side at the pelvic brim, which are the images on your right. But the overall picture continued to be that of limited disease. The sites that were picked up on CT were again better characterized, which are the images on your left. The small bowel was seen to be stuck to the lesion on the right flank, as was the lesion to the sigmoid, and a small bowel resection and anterior resection was likely. At surgery, these needed to be performed as predicted, and the disease on the neoperitonealized tissue of the iliacs next to the ureter could be excised and complete cytoreduction was achieved. We probably got lucky there. And interestingly, there was no small bowel disease as confirmed on the diffusion-weighted MRI. So this is a lady who had limited disease and then underwent complete redo cytoreduction surgery. Diffusion-weighted MRI is a useful tool. The restricted diffusion caused by the high cellularity of the peritoneal lesion makes it stand out as hyperintense on the DW images. You can see those lesions as white or bright, as the case may be. And what the diffusion-weighted MRI does is, and this is speaking to my radiology colleagues, that it takes thinner slices and sometimes can take an hour to perform. Mannitol is used to distend the bowel and buscopan to slow peristalsis. Diffusion-weighted imaging is then used to correlate findings, especially small bowel disease, which we all know can be the rate-limiting step in achieving complete cytoreduction. A study that had been published from the Netherlands Cancer Institute in the BGS in 2019 did show that the interclass correlation between readers, that MRI PCI had a stronger correlation with surgical PCI than did CT PCI. The concept of maximal tumor debulking was proposed in 2013 as an alternative to complete cytoreduction surgery in HIPEC in patients where complete removal of tumor is not possible. Major maximal tumor debulking usually involves a great omentectomy, lower abdominal peritonectomies, and an extended right hemicolectomy, and alternatively to decrease morbidity associated with an anastomotic leakage, a total colectomy and endoileostomy. In women, bilateral oophorectomy is additionally performed. In our latest study of 1,000 patients that I had alluded to before, a quarter of the patients underwent maximal tumor debulking with an acceptable morbidity of 14% and a mortality of 1.7%. The 5-year overall the overall survival for this procedure was 40%. Critics can, however, argue and suggest that subjecting these patients to palliative surgery probably is of no benefit because the disease is anyway slow growing. We tend to perform maximum tumor debulking when complete cytoreduction is unlikely and the patient is symptomatic, or to give relief of symptoms from acute obstruction, intestinal fistulation, sepsis, or to improve what Brendan has termed as obstruction-free survival. Als and Brendan published on the quality of life, where they looked at 49 consecutive patients over a 1-year period. 20 patients had major tumor debulking and 26 complete cytoreduction. Patients who had major maximal tumor debulking started with a lower quality of life pre-op and gained most in the first year post-operatively compared to those who had complete cytoreduction. Both groups reported a clinically significant improvement in emotional well-being, appetite, global health-related quality of life at 1 year following surgery. For those patients who have recurrent disease and who've already had cytoreduction, and this is going back to major tumor debulking, if their colon is mostly intact and they're running into problems with recurrent disease in terms of distension or subacute obstruction, we tend to perform maximal tumor debulking for the same rationale. Our radiologists usually give us a good idea of the condition and length of the proximal small bowel to make an assessment whether a safe end ileostomy is likely to be feasible. What when there is extraperitoneal recurrence? In this 2017 French study, it was found that curative intended treatment of relapse was achievable in 76% patients, leading to a 5-year overall survival rate of 84% when there was isolated peritoneal disease, 77% for isolated extraperitoneal recurrence, and 53% when synchronous extraperitoneal and peritoneal recurrence was present. This is a small cohort of selected patients, but shows that treatment with curative intent can be offered when there is peritoneal or extraperitoneal disease recurrence. Extraperitoneal recurrence mostly affects the pleura and lungs, and these should actually be considered separately. Chua et al. From Sydney and other studies have shown that thoracic cytoreduction and HITOC can prolong survival up to 55 months in PMP. Radiofrequency ablation can be proposed for oligometastatic parenchymal disease. Sugar Baker has published on HITAC, which is hypothermic thoracoabdominal chemotherapy, in 2012, with long-term survival of 50% at 5 years, despite high morbidity. We in Basingstoke have not performed any HITAC, but few cases of HITOC have been undertaken where the cardiothoracic surgeons have been involved. This lady had complete cytoreduction surgery under our care in 2008 for mainly 3-quadrant PMP from an appendix primary. The left upper quadrant was relatively spared at the time of surgery. The right diaphragm was stripped at cytoreduction. Few years later, she was noted to have progressive disease in her right chest. She underwent a vasectorectomy and decortication and HITOC in 2015. This is a last CT in 2021 on the right, which showed that there was some recurrence anteriorly, which was progressing, but the overall picture in the chest remained much improved. The abdomen remained mostly disease-free, apart from some small recurrence next to the spleen. Recurrent disease progression and involvement of the abdominal wall is a challenge. Progressive disease, where the mucin gets infected, can present as abdominal wall cellulitis, Often the infection points and bursts or must be drained if the patient is unwell with it despite antibiotics. But this then usually results in an intracutaneous fistula, as there is nearly always an internal communication that precipitates the infection. Sometimes Mucin's disease can start fistulating around the stoma site as the disease progresses, making stoma management a nightmare. Other times, the disease progresses to a fungating mass. These pictures are courtesy to Emma Maltby, who is a stoma specialist nurse, who, along with a team, do a fantastic job in managing such cases. These pictures are of a patient who developed a high output fistula in the middle of the main fungating mass, and the stoma stopped working. Eosin 2% paint is first applied to the surrounding skin, and then the hypercolloid stoma washers, which are sealants and paste, to create a flat base so that a wound manager can stay. Eosin 2%, which is readily available, not only protects the damaged skin, but also facilitates to keep it dry so that the stoma washers, paste and back can be applied. The use of eosin has been published in the management of high exuding wounds, including treating ulcers secondary from pyoderma gangrenosum. Less exudate and improvement in patient discomfort levels have been reported within 48 hours. Those patients who have major tumor debulking at the index operation, or those who recur after complete site reduction surgery, and in whom further surgery is not deemed to be beneficial, or those in whom incomplete tumor debulking was only possible at redo surgery. When all these patients are added up, they reach approximately 50% of patients who have to live with residual or recurrent disease, which progresses over a period of time. This is a fair number of patients. Treatment options in these patients include wait and watch with monitoring by symptomatology, systemic chemotherapy with palliative intent, palliative care, or TPN. In these patients, as alluded before, disease progression can result in intestinal failure, manifested by bowel obstruction, abscess formation, and both internal or external fistulae or fungating tumors requiring frequent removal of jelly, debridement of loose mucinous disease, and wound management. All these lead to poor quality of life. Patients with intestinal failure who go on to TPN tend to survive less than a year. A small case series published in the European Journal of Clinical Nutrition found survival up to 9 months. From our unpublished data of 15 patients on home PM, apart from one patient who was an outlier with intermittent bowel obstructive symptoms and was given TPN intermittently, those on regular PN had a mean number of TPN days of 8.4 months across all disease categories and a mean number of 10.2 months for low-grade disease. Stephen Prescott was an English professional rugby league footballer who played as a fullback in the 1990s and 2000. His disease was unfortunately quite extensive when he presented with low-grade PMP, and only major maximal tumor debulking had been possible with an end ileostomy, which he had in 2006. He was okay for 2-3 years, but then started having increased frequency of small bowel obstruction. In 2013, he approached Anil Vadia, who was then one of the transplant surgeons at Oxford, inquiring about intestinal transplant for his condition. Anil then contacted Tom and Brendan, and the idea of small bowel transplant for inoperable PMP was considered for the first time. The Basingstoke team then worked very closely with the Oxford team under the leadership of Peter Friend and Shrikant Reddy, and Stephen's transplant was the first one performed in 2013. He unfortunately did not make it from the surgery. The 5-year NHS data for patient survival for elective first intestinal transplant is more than 60% when the liver is not included. This in part offered a rationale that PMP patients with no further surgical treatment options, if offered a transplant and if it was successful, would lead to improved survival, improved quality of life, and freedom from PN. So a criteria for patient selection in PMP has been laid down, and this includes when there is no option for further cytoreduction surgery, when the disease histology is low grade or the disease is slow growing, when there's intestinal failure or abdominal wall failure or both, where patients are on TPN or are predicted to go on TPN shortly, where there's a limited life expectancy of 6 to 12 months, and there has been agreement at the peritoneal malignancy SMDT and the small bowel transplant MDT that patient selection is appropriate. The goal of surgery is to remove the involved viscera, which includes the stomach, small and large bowel, and pancreas, and abdominal wall in cases of abdominal wall failure. Altogether called the explant, and achieving, if possible, complete cytoreduction, leaving behind the liver, ureters, bladder, and the retroperitoneal structures. A modified multivessel graft is then put in place. In some cases, it is possible to keep the stomach, duodenum, and pancreas, and only an isolated small bowel transplant is required in these cases. An abdominal wall graft with inferior epigastric blood supply is used when there's abdominal wall failure. Shrikant, whose talk is next, will explain all this and much more. And I shall hand over the podium to him. Thank you very much for listening and your kind attention.
Thank you, sir. It was really whatever thing we can ask, all those points you have covered here. Few questions, we are inviting here, few questions and a few doubts from my side also. When you see a high-grade recurrence, how do you take a call to go for the re-CRS or to just take them for a systemic chemotherapy? What is the deciding point? Whether to go for the upfront CRS second time or to give a chemotherapy challenge and go for the CRS?
So as I alluded before, the main things would be how quickly they recurred and how extensive the disease is at the time of recurrence and how high the tumor markers have risen by the time they recur. So all of this basically tells you that the biology is probably not something that we're going to win from, and we would advise or propose that these patients be tried on some chemotherapy. And then if their disease remains stable thereafter, then possibly they could be considered for cytoreduction, but again, more if the disease is focal or limited as opposed to widespread disease. And the other thing that is also important is how extensive the surgery was in the first sitting. If all the peritonectomies have been performed, if it was a very difficult pelvis, if things were very stuck, and you know that you've disrupted all the peritoneal planes and there's, let's say, pelvic recurrence, then you have to think twice before really rushing into surgery, which is why I gave the example of that disease over the iliacs and the ureter on the left side, which was easily missed on the CT scan, but was picked up on the CPM MRI. The only reason why we took her for surgery was because her chemotherapy options were limited. She was a young patient, she's 40, and her small bowel was free.
Thank you. The other question, in your experience, you're a proponent of the prophylactic CRS and HIPEC. So did this strategy and any changes you're seeing and because of prophylactic HIPEC recurrence rate has reduced or number of CRS.
So that study was published a few years ago, and what we are doing is we are collating all the cases who've had the surgery since, and hopefully we should be able to come up with better numbers. That was a small study of 62 patients, but it's interesting that the Japanese study that I quoted right at the beginning of the talk talks of peritoneal recurrence when there is perforation and high-grade disease as high as 45%. So there is, so I think the chances of developing peritoneal disease with high-grade appendix histology is probably high, and we advocate being aggressive in terms of management. And even if you were to allude to Sugarbaker's study, even though all his 299 patients had complete cytoreduction, so many of them were dead because of peritoneal disease recurrence. And it was not the lymph nodes that was driving the progression.
Any special technique to close the abdomen, because you have shown the thing. So in due course, this is a regular, they fail during a lot of leucine comes out. So anything, a small thing, any suggestion on that?
Sorry, I didn't. Any suggestion to close the abdomen?
Yeah.
Not really. Just meticulous closure. We normally don't leave closures to fellows in house offices. Let's put it that way. I think in Basingstoke we have an approach where 2-3 of us scrub in during a day because we operate so many cases. So usually, it is done under supervision. You just have to be meticulous. But we don't use anything specific unless somebody in the audience thinks differently. We haven't done any study on this, to be honest.
Because when it fungates, those are the horrible things. That's it. Oh, thank you.
Sorry, say that again?
Thank you. That's all from my side, sir. Robin, sir.
Dr. Ramakrishnan has a question. Dr. Ram, would you like to go first?
Yeah, thank you, Aditi. Thanks, Sanjeev. That's a very comprehensive coverage of managing recurrent PMPs. I was quite intrigued by your presentation regarding debulking surgeries for advanced tumors. I have a couple of questions related to debulking surgery. One, in a primary, when you do it for the first time, you find that complete cytoreduction is not possible, and you do a maximum tumor debulking. Do you think in the back of your mind that, okay, at some point of time later, maybe after 6 months or 1 year, I have a possibility that I might come back again and open up the patient and try to achieve a complete cytoreduction at a later point of time?
So Rama, I think we land up doing maximal tumor debulking, and that is solely governed on how the small bowel is looking. So disease elsewhere really doesn't matter too much. So let's say there's quite a lot of disease around the antrum and you think the patient needs a distal gastrectomy. Or let's say the porta is very difficult, or the aortocaval groove is very difficult, or the liver is really encased. In those patients, we would not go for major tumor debulking. We normally don't even go for a staged approach like Manchester do. We tend to go for it if the small bowel is okay. Only when we know that whatever you do, you're not going to change the status of how the small bowel is going to look like, and disease is going to progress further. That's when we decide on maximal tumor debulking, which usually involves the lateral peritonectomies, radical lumpectomy, colectomy in most cases, because half the time you're thinking, one, yes, there could be complications from an anastomotic leak, and other times, patients can get obstructed distally. So to kind of improve what Brendan has coined as the obstruction-free survival.
And would you perform debulking surgery in case of a recurrent PMP when the CT clearly shows that you're not going to be able to achieve a complete cytoreduction anyway? So you still consider the option of a debulking surgery if the patient doesn't have any of the features you suggest, like
no,
obstruction or fistulation?
Only symptomatic. So then you go back to the study of quality of life. So only if the patients are symptomatic, because see, you've already done, and often, yeah, the situation gets tricky because they've already had most of their colon out and things like that. So there's not much you can do apart from removing the mucin and whatever is causing the abdominal distension. But only if patients are symptomatic, there's some merit. But if the patients are asymptomatic and there's disease recurrence where we think that complete cytoreduction is unlikely, then we won't go in.
And there's a grade.
That's why if you see, all the redos that were done, more than 50% on both occasions, complete cytoreduction was possible. That only means that we are selecting our patients very carefully.
And does the grade of the tumor influence your decision on debulking, doing just a debulking as opposed to a complete cytoreduction? You do it for a high-grade tumor?
Very rarely, until unless the patient is really symptomatic and you want him to probably have a little better obstruction-free survival so that he may go on to have some systemic treatment, things like that, but not really for high-grade disease, no. This is usually for low-grade disease because, all these operations can have complications of their own, and the last thing you want is, you worsen the quality of life.
Finally, I know this goes against the principle of HIPEC, but have you ever performed HIPEC after a debulking surgery?
We do, but often only when there is more mucinous ascites. I mean, you could argue, you're absolutely correct. You argue that, this is not so much for disease penetration, it is for ascites recurrence, which can sometimes be the case, as there is little evidence that shows that sometimes it decreases the rate of reaccumulation.
Thanks, Sanjeev.
Okay. Sanket, do you want to ask your question? Sanket, your hand is...
Sure. So my question was, is there any role for, we have patients who are treated at other centers who come to us very late in the progression of their disease with a lot of mucinous ascites in a low-grade PMP, where the small bowel is extensively involved. And is there any role for laparoscopic mucin evacuation, and what is your experience, or what is your take on this?
Is this Sanket? Who's this, sorry?
Yeah, this is Sanket.
Hi, Sanket. Yeah, hi. Sanket, honestly, I haven't performed any laparoscopic mucinous evacuation. We have performed it's not really a mini laparotomy, it's over the maximal point of mucinous distension where the small bowel is actually compartmentalized, and know that you can go in and evacuate mucin and then close the abdomen back. We have experience in that, and some of our patients have had repeated evacuations and are still going on. And this is, there's a couple of patients that I remember that we've evacuated mucin on different occasions now for at least 1.5 years. And these patients have had at least 3 or 4 evacuations. So to answer your question, I suspect there is a role of mucinous evacuation, depending where the mucin is lying, how compartmentalized the bowel is, and whether you can get in and out safely. And if you can do it open, I suspect you can do it laparoscopically.
Yeah, so our experience, is of course select patients, but it does help whenever the mucin evacuates, it kind of, as you said, compartmentalizes, and then it causes pressure symptoms and patient starts losing weight, and you evacuate, and again, they go on better for a while. So,
no, I would agree. I would agree. Yeah.
Right. And just to comment, fantastic presentation. Very, very well summed up about everything. Thank you. Thank you.
Thanks.
Okay, so I get to ask a question since I'm the host. So though we are running out of time, I'd like to ask you, how do you select patients for follow-up? Where you do a close follow-up and do not choose to operate. You talked about a wait and watch policy. And my second question is that if during surgery, you often don't pick up these small bowel nodules, and especially in high-grade disease, some of these nodules are on the mesenteric border where you have to perform a bowel resection. So what do you do then? Do you, still debulk or just open and close? And how many bowel resections do you perform in such a case? It's a redo case.
If it's a redo case?
Yes, it's a high grade, sometimes many times you find these small nodules on the mesenteric
Yes,
side.
so you're talking about biliary disease, isn't it? Yes.
Yeah.
So as I said, yes. So as I said, I think we have evolved a little bit more, and our radiologists have become a little more experienced with the diffusion weighted MRI. And we tend to rely on the DW MRI if we can't laparoscope these patients. So either you laparoscope or you do DW MRI. We really wouldn't jump into surgery even if there was limited disease and the disease was high grade, because then more often than not, you go in and you find disease distribution just like you've explained, and the results are suboptimal.
But they get missed. Sorry to interrupt you. No, they get missed even on the MRI. MRI doesn't pick up.
Yeah, you're right. Every test has its misses. And if, let's say, we go in and we find miliary disease and it wasn't picked up preoperatively, then we won't, then surgery is not going to really benefit the patient. So there's no point doing major tumor debulking. There's no point doing any surgical intervention. You're better off closing the patient up and sending them to the oncologist, because your hands are tied. I wouldn't go about resecting disease and subjecting patients to many anastomosis, potential complications that will delay his further treatment, or further potential treatment rather.
All right. And what about the wait and watch, the selection of patients for wait and watch?
Yes, what we tend to normally do is we would normally, if there's confusion regarding intraoperative findings, we normally get the surgeon to write to us, or we look for the operation note just to make sure what the line of the lie was at the time of appendectomy. And that's what then helps us decide. By that point of time, by the time the patient gets referred, they would have already had tumor markers. They probably would have had an early CT scan, and that'll give us an idea as well to then decide which way we're going to go in terms of surveillance, or do we actually do a quicker scan, reassess things, and decide how we're going to play this.
No, my question is about patients with obvious recurrent disease. You've done a CRS and HIPEC, it's low-grade PMP, the patient's recurred. And do you ever adopt a wait and watch strategy when you can see disease on imaging, but the patient
yes.
Disease?
So if you saw that slide, when we talked about the outcomes of our patients where there's a dilemma how to manage recurrence, only a third of the patients had cytoreduction, and in the 2/3 patients, half of them had palliative and half of them were wait and watch. And if you plot the survival curve for all these patients, the curve that comes on top is the curve of patients who had cytoreduction. Then it is maximal tumor debulk. Then it is wait and watch, followed by maximal tumor debulking, and the last is palliative chemotherapy. So yes, to answer your question, we do follow the wait and watch approach. lot of it, again, depends on how quickly the disease came back, how extensive it was, and things like that.
An extension to Dr. Aditi's question. So here, when you follow them up, each time you're doing MRI and corroborating with the tumor markers.
So if you look, yeah, so if you look at, if you look at the, so the protocols that we have, even for maximal tumor debulking, followed similar imaging. So it's usually CT scan, and there's usually tumor markers. When they, so let's say there's disease recurrence, and you know that there's extensive small bowel disease. There's no point in doing an MRI because it's not going to add very much. It's not going to change your management. You're going to wait and watch anyways. We just have to see what is happening to the disease progression, and if the patient is likely to become symptomatic, obstructed, so you can advise the local team, or perhaps consider something to improve obstruction-free survival. Again, everything palliative.
Okay. Fine. Okay.
Thank you, sir. It's wonderful presentation. Almost all the parts are covered. Over to Dr. Aditi.
Yeah, thank you, Dr. Sanjeev, once again for that very comprehensive talk. We will now move on to the next session, and I'll invite Dr. Ramakrishnan to introduce the next speaker.
Thank you very much.
Thank you.
Thank you, Aditi. The next talk, I believe, is on the role of small bowel transplant for advanced pseudomyxoma peritoneal. And to give this lecture is Dr. Srikanth Reddy, who is a consultant hepatopancreatobiliary transplant surgeon at the Oxford Transplant Center. And he, I believe, is part of the team that performs multivisceral transplant for PMP at coordination with the Basingstoke EMI. So over to you, Dr. Srikanth. We look forward to hearing your talk.
And I'll share my screen and I'm just struggling to share the screen. I'm not sure what is the problem.
There are some things more complicated than a small bowel transplant at this.
Yeah, definitely. It says open, okay, and security, and I'll say is.
Perhaps you have to click on that specific window.
Yeah, I mean, it's system preferences.
Could you try on your PC? Is this the hospital computer?
Yeah, no, this is my laptop in the hospital. It's,
Oh, okay.
It says go to security and privacy to grant access. And when I go to security and privacy, it's not sure why. Let me see. Security system preferences.
Is there a firewall?
Yeah, no, the firewall is off. Yeah.
Is it possible you could mail the tracker to you and display it from your end?
Yeah, and I could share it on Dropbox because the file will be large to email it because of the photographs. So let me, yeah, I could try. Sorry about this. I'm not sure. Security and privacy, and yeah, it says Zoom is allowed. Means I'm not sure. Means
Okay.
I've.
So if you have time, I would suggest that while you mail it to us, we
Try
go
once
on to the third lecture.
Yeah, I think let's do that. Yeah.
If you are
that's
not
fine.
in a rush, I think we should do that.
Let's do that. Yeah.
Yeah. So, yeah. Thank you, Dr. Farid. And Dr. Rohin and Dr. Sankit will moderate this session.
Can you see my slide there?
Yes.
So, so thanks for the opportunity to talk to you all. And you've heard from Sanjeev, and I'm sure some of the slides that we're showing will be similar. And we'll hear from Shrikant about with transplant, multivisceral transplant. But I thought I would talk to you about complications and how we manage them. And we have our fair share of complications, unfortunately. But I guess the only way you get no complications is if you don't operate. Most of you will know that we are one of the 2 national centres funded by the NHS to treat.
Dr. Faiz, I'd like to
I've got
interrupt.
you on. Yeah, sorry.
We are not
Can you see
seeing
now?
the presentation.
Yeah.
Oh, just now. Okay, yeah, now it's better.
Yeah, sorry. Okay. So you'll know that we are one of the 2 national centres funded to treat pseudomyxoma peritoneae. The other is in Manchester. We've been doing this for 25 years now, and we're about to celebrate our 3,000 cases. So we're currently doing about 8-9 cases a week. Majority of them are pseudomyxoma from appendiceal tumours, but increasingly we're treating colorectal peritoneal metastasis and peritoneal mesothelioma. So, you know, those of you who deal with pseudomyxoma, this will be a fairly familiar sight. You can see the compartmentalization of the small bowel, large volume ascites. This is probably less favorable. You've got what Paul Sugar-Baker would describe as œuf brouillé, or scrambled eggs. And you know that it's unlikely you'll be able to achieve a complete cyto reduction. But you know, whether we do a complete cyto reduction or a tumor debulking, in around 10% of patients, certainly now most recently, we'll see grade 3 or 4 Clavien-Dindo complications, and about 1%, meaning currently we quote between 1 and 2% mortality. So again, those of you who undertake this type of surgery know exactly what's involved. So if we wanted to achieve a complete cyto reduction for pseudomyxoma, if you've got 4-quadrant disease, that often involves stripping the diaphragmatic peritoneum, greater omentectomies, anterior resection, appendicectomies, or a right hemicolectomy. In a proportion of patients, we need to perform either a distal or a total gastrectomy. We've done about 100 distal gastrectomies, probably about 8 or 9 total gastrectomies less recently, to achieve a complete cyto reduction. So I think unless you're prepared to do all of those things, then you won't achieve complete cyto reduction. This is our
again, you've seen this graph. If we can achieve a complete sites reduction, we can get a pretty good 5-year overall survival and 10-year overall survival. But if we can't, we can still give patients a survival benefit with a reasonable quality of life. Now, in doing that, as time has gone on, our volume of the volume of cases that we do have increased. We've got better at achieving a complete sites reduction, and our median length of stay probably hasn't changed much. For large volume pseudomyxomas, it's still around 3 weeks, despite various attempts at trying to reduce that. Certainly for colorectal peritoneal metastasis and mesothelioma, it's around 2 weeks. Patients don't need to be in for as long, and the extent of their surgery is much less. We don't take patients on with colorectal peritoneal metastasis with that degree of disease, and so they're usually out of hospital much quicker. And our tumor debulking rate has reduced. But yeah, 10 hours seems to be the magic number. If you look at the complications, and if you divide our experience up into quartiles, so over the last 20 years or so, initially we had fairly high grade 3 and 4 complication rate, and that's come down, as I say, to just under 7% now. So the most recent morbidity, mortality, we've managed to bring right down to more acceptable levels. I just put this in just to give you an idea, just put context of our 25 years experience. So just under 2,000 patients have had CRS and HIPEC for pseudomyxoma, and about 1,500 of those have had a complete sites reduction. But if you look at the time over which those patients were operated on, this graph is actually just from a recent paper on early postoperative intraperitoneal chemotherapy, EPIC. But it's really just to give you an idea of how long it took us to operate on those groups of patients. So the first 391 took us 206 months. The second 391, 42 months. And then you can see most recently we operated on 391 patients in 22 months. So, 12 years to operate on the first 391, and only 2.5, just under 2 years actually to operate on the most recent. And that just gives you an idea of the volume that we're going through at the moment, but also what it means to essentially look after those patients, and we'll touch on that. Brendan's published on the learning curve, decision-making, technical factors, and he frequently says decisions are more important than incisions. And I think that's very important when you're selecting patients for treatment like this, and also minimizing complications post-operatively. There's a team of us, so this isn't a one-man band or a one-woman band. We don't have any women, actually, so that's where we're lacking at the moment. I think it's always good to have more than one person involved, particularly when things go wrong. We have a temptation as surgeons to minimize problems and sweep them under the carpet if we can. Sometimes you need a bit of objectivity. So we have a rule that if you have a complication, you take someone else with you when you're going to sort it out. I think there's an old adage, don't F up the F up. So it's a good way to look after these patients. I think make sure that you phone a friend and you get some advice when things don't go to plan. This is Brendan's paper. He struggled to publish it, but essentially it's 2006 it was published, but it was his initial experience. Looking at the mortality, it was nearly 20% mortality in the first group of patients that he operated on. And he started when the service started, and essentially it was him on his own. And we've been able to bring that right down, as I say, to just under 1% through a number of different methods, but mainly increasing volume, but also having more people around and support from a wide variety of multidisciplinary teams. Some of you may have come across this quote from Will Rogers, who's a comedian in the US in the 20s and 30s. Good judgment comes from experience, and a lot of that comes from bad judgment. Lucky is the person who learns from another's mistakes. And I guess, you know, that this idea of the global learning curve means that we can share experience in meetings like this, in discussions like this, and hopefully save people from making the same mistakes that we've made. So when we're treating patients with advanced pseudomyxoma, often they're malnourished, there's muscle wasting, they've got massive abdominal distension, there's disturbances in their blood clotting, they're prothrombotic, and there can be a wide age range, which has its own implications. For us, one of the most kind of concerning things is the risk of venous thromboembolism. And the young patients that we've had who have died after size reduction have died from PEs, pulmonary emboli, usually, you know, close to their being discharged. So if anyone now has a history of venous thromboembolism, either DVTs or PEs, then we'll prophylactically put in an IVC filter. This is controversial, and there are, you know, people who think this is overkill. It's a waste of time, and obviously it will only prevent lower limb DVTs traveling up to the lung. It's not going to prevent upper limb DVTs or PEs spontaneously arising. But to be honest with you, if you've got large volume abdominal disease, then you'll have stasis in the IVC. In the lower limbs, you've often got edema, and so we've adopted this policy essentially where we get these IVC filters placed a few days before people come in for surgery. And this is a recent publication if anyone's interested in looking at that. Intraoperatively, we use the high-powered diathermy. There can be significant shifts in fluid, and blood loss can also be marked. The intraperitoneal chemotherapy itself, we need to be cognizant of and the risks attached to that, although on the whole, with the dose of mitomycin C that we use, which is essentially the mainstay, we use 10 milligrams per meter squared, which is probably lower than anyone else in the world. But as a result, I think we get far less toxicity, post-operative toxicity attached to that. And it also allows us, I think, to combine an EPIC with 5FU without too much without too much trouble. When you're stripping the diaphragms, then we routinely place chest drains. We probably, again, put in too many chest drains. And we're looking at using a smaller bore drain, but also selectively draining the chest after a diaphragmatic stripping. So if someone's had bilateral diaphragm strip, perhaps just draining one pleural cavity rather than both, because these chest tubes can be painful and they're not without their own complications post-operatively. We put those drains in after surgery once the abdomen's closed. When we were putting them in intraoperatively, we were finding quite a high incidence of empyemas and intrathoracic infections. So now we close the abdomen, we'll get re-scrubbed and then put the chest drains in right at the end. We know that we're all quicker ourselves as surgeons, and certainly working together and working in a high volume setting just hones your surgical expertise. So we can do things more quickly, and we tend to work as a tag team. So one of us will be operating for 3 or 4 hours, and then we'll rotate so that we can keep the momentum going, but we can also train, so it allows our fellows to do various parts of the operation without slowing things down too much. I think if we know that if a size reduction is going to go beyond 10 hours, then that tends to result in more post-operative complications, I think, for a number of reasons. The patients don't like to be asleep for too long. Our anaesthetists are all dedicated to peritoneal malignancy, so they're used to anaesthetizing these patients and dealing with the challenges that they bring. And we're also very lucky to have very engaged hematologists. Ashok Roy has been with us for nearly 30 years. He's retired, but he's come back to work with us on a research basis. And Ashok's done a huge amount of work looking at how we manage the bleeding and clotting in these patients. And he identified very early on that the fibrinogen level drops quite precipitously in patients with pseudomyxoma. It's often very high preoperatively, but when it drops to below 2 grams, then it sets off a whole clotting cascade, which is very difficult to correct. And so we've done a lot of work using ROTEM to get real-time measurement of clotting, because if you send a clotting sample off to the lab, it's usually an hour and a half, 2 hours out of date by the time it gets back to you. But we've been running a few trials using fibrinogen concentrate to move away from we stopped using fresh frozen plasma and platelets a long time ago. We've moved to using cryoprecipitate to control bleeding, to replace fibrinogen. But now we're using these new fibrinogen concentrates. So there may be some role in that. This is just a publication from a few years ago looking at patients undergoing CRS and HIPEC. And as I say, we were using FFP, but we switched to tranexamic acid and cryoprecipitate, and we found that we could reduce our blood loss quite significantly. We stopped using FFP, and we stopped using platelets, and we switched to using cryoprecipitate. But now the next step really is using fibrinogen concentrate, which is a safer product. It can be given very judiciously, but also using an algorithm and the ROTEM, you can replace fibrinogen in a guided way to reduce your incidence of venous thromboembolism, which is the other side of the coin. If you give too much cryoprecipitate and too much fibrinogen, then these patients get DVTs and PEs. So I think that this has made a big difference in how we intraoperatively and postoperatively manage the patients, but also the morbidity that comes with this type of surgery. Postoperatively, we need to restore patients' physiology. Pain management is a big issue, so we have a dedicated pain team. All of our patients have thoracic epidurals. We try and mobilize them on day one, but that requires a lot of nursing support. We tend to keep the epidural in for 5 days or so, and then take the epidural out and switch to a PCA. Hallucinations is a big issue, and we've introduced a number of things to help our patients. We know that it's a problem sometimes changing the PCA drugs, or the PCA drugs can help, but often preoperatively some counseling and preparing patients for this will help them deal with it. The logistics of postoperative care is not easy, and we certainly rely very heavily on our anaesthetic colleagues. So some of you will have met John Bell, who's one of our consultant anaesthetists. Patients on average stay about 2 days in ITU. Some of them stay longer, some of them go back to ITU, most of them for re-intubation and ventilation. Some of them need a tracheostomy, but we get great support from our critical care doctors and our anaesthetists. TPN, so feeding, parenteral nutrition. Again, there's a lot of, there are different schools of thought around this. We've always been proactive, and so everyone who has a situs reduction for pseudomyxoma will get a central line and will have TPN feeding from day one. So we won't wait for them to see how long it takes for them to get their gut function back again. And when we did an audit of this, it's very rare for people to be able to eat and drink under 5 days after this situs reduction. It may be because when we do our omentectomy, we don't preserve the arcade, the gastrocolic arcade. I know the French do that, and I think they feel that allows restoration of intestinal motility more quickly. It's difficult to know. The HIPEC obviously will slow things down, and patients can get an ileus. So we don't really waste time, but we feed people straight away parenterally. The line that they're fed with, we tend to change routinely at day 7. Again, we may be changing too many lines, but I think we're concerned about line sepsis. The second line, so the second line they get put in is a silver impregnated line, and so that can stay in for much longer without a line change. But most patients will require a line change and then TPN for about 10 days or so. And once they're able to eat and drink, their stoma's working or they've opened their bowels, then we'll stop the TPN. This is Nancy Vanderpoy. She's our clinical psychologist, and she's been with us for a few years now, but she's made a real impact on the recovery, certainly the psychological recovery of our patients. She's helped us to manage hallucinations, which was a real challenge for the nursing staff and for the patients because they can be terrifying. Patients become delirious or they become confused, agitated, they pull out their lines, and it can really set them back. But Nancy will assess patients and she'll give them a color coding rating, so they're green, amber or red, depending on their risk of developing psychological distress post-operatively. And she puts the place, so she's now building a team, so everyone will be assessed by her, and if there are any problems, she'll flag them to us pre-operatively. This is a list of all the things that might go wrong and do go wrong. And those of you who undertake size reduction will have, I'm sure, had to manage some of these things. And so that's pretty much everything that could go wrong with this type of surgery. So you really need a lot of friends, radiologists. We rely heavily on our urology colleagues. We try and involve them early so that they can preempt the problems. And certainly we don't feel so bad when problems do occur if they've been involved. And they appreciate that involvement. We get a lot of help from our interventional radiologists, and we try to manage most of the intraoperative collections, post-operative collections radiologically, and avoid reoperation if we can. We have a dedicated ward, and again, we're very lucky to be funded centrally by the National Health Service. So that allows us to provide a good environment for the patients, and they're protected from the general kind of hubbub of a hospital, separated from the emergency patients and from other elective patients. So the nursing staff know what they need to do. They're all trained to look after these patients and to pick up signs early if things might not be going to plan. This idea of crew resource management, I think, is very important. So it's not only a surgical learning curve, but there's a institutional learning curve. And if everyone works well together, they're accessible, they're approachable. If things are going wrong or people pick things up, then they need to be able to escalate that, and they need to be confident that they'll be listened to and that those concerns will be acted upon. And I think that we've been very lucky to have a team that feels comfortable doing that and identifying problems early. These are just some of the people. This photograph's a few years old now, actually, and now we probably couldn't fit everybody on that staircase, all the people who are involved in looking after our patients. And this is just a bit about failure to rescue, this whole idea that, if something is going wrong, then you need to be looking out for it and then act rather than letting things drift. And so it's not just the volume of patients that a centre is dealing with, but it's also the expertise and the support from anaesthetists, radiologists, and that all impacts on the quality of post-operative care. And that's what gets patients through surgery like this. It's not just the surgery. In fact, that's just the beginning. Again, this is a recent publication from SOGI looking at the volume and the number of cases that seems to be the trigger above which complications tend to drop. But it isn't just the volume, as I say, it's the expertise that you've got available. This is a Dutch paper about mentoring and about supporting new centres. So you can see here Pioneer Institution in blue, their first 100 cases, and then the green line is the most recent 100 cases. And you can see if you've got an experienced centre that's mentoring a new institution, you can lower the morbidity, the significant morbidity, the duration of the surgery and the blood loss to get it in line with the most experienced centres, so they don't have to go through that learning curve like you did. The ESSO has a fellowship, and this mentoring allows different centres or experienced centres from across Europe to support people who are setting up these centres to manage patients like this. And I think this combination of training, mentorship, and the resources that it brings, and the teamwork is really useful. Some of you would have come across the Dunning-Kruger effect, and I think, as you, and this is actually a publication, but I think your confidence is probably out of kilter with your experience initially when you start out at this. Anything's possible, you'll take on anything. And when we look back at the patients that we selected perhaps 20 years ago to operate on, it's very clear that as we become more experienced, your confidence in getting those patients through drops, and then there's another pick up again at the end when you think, as you develop experience and you make those bad decisions, you learn from that. This is, some of you know, this is Michael Ryan, who works for the WHO, and this, I think, these quotes, that they resonated with me. They're he used them when he was describing the WHO's response to Ebola virus, in terms of moving. But I think if you pick up a complication, if you think something's not going to plan, then don't just sit on it. Be fast, have no regrets. Investigate it, do whatever you need to do, and then deal with it. Because if you let it drift, then invariably the outcome will not be good. I think, again, speed trumps perfection. If you're waiting to get everything right or have all the information, then again, you're probably going to miss the boat. And the greatest error is not to move. And as I say, it's human nature to try and minimize things and say, well, actually, no, it's not a leak. It's just a chest infection. Let's just put them on some antibiotics, increase the oxygen. And then it takes often someone else to come in and say, well, hang on a minute, let's do a CT. And then there you go, you find your leak. And then you can deal with it. But I think working in a team and having colleagues that you can rely on and trust is really helpful and invaluable in situations where patients have complications. Thank you. So, any questions?
Great talk, Dr. Faiz. Once again, as always, very interesting. Can you hear me? This is Sanket here.
Yeah. Thank you, sir.
Yeah, and always a pleasure meeting you. I know everybody who's there in the attendee list has already seen quite a few of your talks. So, regarding the complications, what I had heard this last time, that you're using a lot of fibrin concentrates, and it's a very interesting concept. Our own pulmonary embolism rate is nearly 10% for PNPs. And unfortunately, these concentrates are prohibitively expensive in India. If this was not available, any other advice how to minimize pulmonary embolism rates, or how to go about this in terms of choice of blood products, or ways to avoid pulmonary embolism? I think for us, that's a big problem.
Yeah, no, it's a fascinating area, and I think we don't fully understand it. We've learned a lot over the last few years doing these trials and measuring clotting using thromboelastography, but also the clotting factors. And what's really interesting is people probably don't appreciate that once you say, for instance, you use diathermy on the liver, high-powered diathermy on the liver, or even if you do a capsulectomy, Glisson's capsulectomy like the French do, you get a drop, but then patients become prothrombotic. So protein C, protein S, all these factors drop away. But the body corrects these very quickly. So although intraoperatively there's this push to give factors to help clotting because you're having problems with bleeding, as soon as you stop the surgery in that first 24 hours, the body does a really good job at correcting things. And so what tends to happen is in that post-op phase, if you're still giving products, cryoprecipitate and fibrinogen, then you get this overcompensation. And that's when you get the thromboembolic events. So yeah, no, I accept fibrinogen concentrate is very expensive. Cryoprecipitate is, not everyone has access to cryoprecipitate, but it's got fibrinogen, but it's also got other factors, so it's not a pure product. You will speak to a lot of hematologists who will say that actually cryoprecipitate for a lot of situations where you have bleeding and trauma, for instance, is a better product than fibrinogen because it'll give you a firmer clot. But actually fibrinogen gives you a weaker clot, which is probably what we need in a situation like this, where our patients become prothrombotic very quickly. Tranexamic acid is helpful. I think platelets and FFP, people still use them, but they probably don't add a huge amount in terms of helping with clotting. But there's still a lot we don't know. And so it will remain, I think, to be a challenge, although we're beginning to understand how the bleeding and clotting changes over the course of surgery and in that first 24, 48 hours.
Another interesting point that you made was change of central line on the 7th day. Was it based on any study institutionally, any experience with PICC lines, any advice on that?
Yeah, so I think it was an empirical thing actually to start with. Brendan just decided that 7 days would be a good day to change it. And we've audited things recently, and we could probably leave those lines in for a few days longer, maybe 10 days or so, and then avoid that second line change. So if you leave the line in for 10 days, because now I think aseptic technique is good and people treat those lines with respect. And they're usually 3 lumen lines, so you're not having to put anything else through them, just the TPN, perhaps another infusion, PCA or something. But if they're looked after properly, then 10 days, and then you can probably take them out and not have to change them. So yeah, it was not based on any evidence, and we're in the process of looking at that, and we're certainly less regimented about changing those lines at day 7 now, and we will leave them for a bit longer if people's gut function is about to return.
Okay, great. Any questions from Dr. Rohin, Aditi?
Aditi, you.
Dr. Shrikant wants to say something.
I think this is, being from India and actually working in UK, I understand some of the challenges across in India and here. What is the minimum? Have you tried to define in a surgeon and per unit of hospital to actually provide good results? I think in some countries, is it possible to do only 5 or 10 cases and be good at it as both a unit and as a team? Have you tried to define the minimum thresholds?
So I think, yeah. So I think from a surgeon's point of view, there have been some publications, and I think if you have an experienced surgeon going to a new centre, I think 40 cases. I mean, Aditi will know the data better than me, I think, but. Got 40 cases for was it Mark Pocard published 40 for the surgeon, but also I think for the centre it's probably not far off that, maybe 50 cases. And I think if you do 50 cases, then everyone who's involved also gets to know what's needed, where the pitfalls are, where the problems are. And a lot of you here, Rohin, Ram, you've all been involved in setting up centres and starting. I mean, what do you think, Rohin?
Yeah, I think the volume is important, but the other factor to consider is the time over which the volume is reached.
Yeah.
I think when you're starting, it's important to fairly do cases regularly. Doing a case in 6 months is not going to make any team. So unless you do these cases regularly, this is not something we must do as a one-off 2 times a year.
Sorry, volumes per year. Sorry, that's what I meant. If I wasn't clear.
Yeah, no, I think 40 or 50 cases a year is probably what you need to be doing to get proficient and safe at this. So that's what 1 week.
Faiz, I guess that holds true for dedicated centers. See, in centers that cater to multiple disciplines, or even in a cancer center where there are so many different cancers to treat, it is quite impossible to get a dedicated team to treat only peritoneal surface malignancies. So even though an individual surgeon may be experienced enough, it is very difficult to get a team that is experienced enough at one time, because the anesthetists keep changing, the theater nurse keeps changing. So I guess in such centers, the learning curve is going to be much higher. That is my take on it.
Aditi, I think we had published a paper of learning curve.
Yeah.
I don't remember the exact data, but I feel that bringing down the complications, you need somewhere around 70 cases, and to overcome long-term complications and 3-month mortality, it was more than 120 cases, if I'm not mistaken. So it's a fairly steep curve, I feel, even if you are an interested surgeon.
So we had, we had evaluated the learning curve in a reverse manner. How many cases do you need to make it safe? We didn't look at proficiency, we looked at safety, and I think the number was 40 in that paper. So we had still not attained proficiency, because I think we had about 50, 60 cases each. That was our early experience. But the SOGI multi-center study, in which only 6 centers achieved proficiency out of 14, I believe that for PMP. The learning curve for PMP in that study by Kuzamura is more than 100 patients for a surgeon and for a center. I mean, especially I'm concerned about the completeness of cytoreduction. It's a very, very subjective term. A lot of centers may avoid complications, but then the quality of the cytoreduction is, it's a very subjective term. If you've not explored the abdomen, you miss disease, you do a less aggressive surgery, it's a complete cytoreduction and you have the complications. So that paper by Kuzamura looks at early recurrence, which is very important. Recurrence within 2 years. So that's a parameter used to evaluate the learning curve. Yeah.
Aditi, can I ask a question?
Yes, please.
Faiz, you had mentioned 17% rate of unplanned return to OT. What is the most common reason for an unplanned return to OT?
It's probably bleeding. So post-operative bleeding, and there's a variety of causes for that. I mean, we had one of our fellows put the abdominal drains, all 3 abdominal drains, through the inferior epigastric. So on day 5, when we took the drains out, patient dropped their hemoglobin, blood pressure, and then when we took them back to theatre, they'd managed to, I don't know if they could have done it if they tried to do it, but every single drain had gone through the inferior epigastric at a different level. So when they all came out, the tamponade had stopped, and so they had a belly full of blood. And we have patients bleeding if they've had a splenectomy from the splenic bled sometimes. So I would say, bleeding is probably the biggest. And then after that, it would be anastomotic problems. But we try and manage the anastomotic leaks non-operatively if we can. And then you just have to accept they're going to be there for months. And again, in a non-UK setting, that's probably, if I accept, that's easier to do than if you were in India, for instance, where there's pressure from all kinds of places and to do something and try and get people better and shorten their hospital stay. I guess that we don't have that pressure so much.
Okay. So I have another question. We are seeing all this emphasis on ERAS, and there are people who say that a lot of these patients need not be managed in the ICU. And your presentation was absolutely old school, and which is pretty much what we do at our centers. What I wanted to specifically ask you is, what about rehabilitation? What is the time to your first consultation, from your first consultation to surgery? Like, you often see a patient who's ready to get surgery the next day or in a couple of days, and you have a slot free where you can fit the patient in. So how do you prep these patients for surgery? Do you have any protocols?
So I mean, the lot of talk about prehabilitation. Many of these patients have large volume disease, big abdomens, limited mobility, and it's been gradual over, kind of 6 months to a year, sometimes even longer. So at the moment now, we can probably list patients in maybe 3 or 4 weeks ahead. But that doesn't really, well, first of all, they're in no physical state really to improve their physiology a huge amount, because they just, they physically can't. So, this idea of wearable technologies and Fitbits and Apple Watches and trackers, and it might work for other cancers, even for a colorectal cancer where you've got a bit of time, but people are physically able to do that. But for most of the patients that we are dealing with, they just physically can't do that. Neither are they able to eat, in a different way. Sometimes they can't eat much at all. So we're not, some places will rely heavily on CPET testing and various preoperative assessments, but actually our anaesthetists are pretty good at, if we're worried about someone, then we'll usually write to John Bell and say, look, we're worried about this patient. Can you just look through their notes and tell us if they need anything more? But most of the times you can get an idea of how fit someone's going to be. But from our own experience, it's limited in terms of how much you can improve their physiology. And so, to answer your question, if you can, often you're not going to improve their nutrition. If we do on occasion get people in for TPN feeding preoperatively, so if you're going to do that, they probably need at least 10 days of TPN. So if we're really, if someone's got really low albumin, we're really worried about their nutritional status, we'll bring them in, admit them preoperatively, give them 10 days of TPN, assess them, and then operate on them. But in that situation now, rather than going for a complete site reduction, we will do a staged procedure, get them out of trouble, and then if they recover, perhaps a year, 18 months down the line, bring them back for completion. Just to go back to what Ram was saying, but that's not because we couldn't remove the disease in the first place. It's a slightly different indication, and I think we're moving towards that rather than trying to do one heroic operation, because nearly all of those patients who we've operated on a semi-urgent basis, they've had significant complications, very prolonged hospital stay. Whereas I think if you can get their physiology corrected by just dealing with either the Krukenbergs, the mucinous societies, get them physiologically better, then they're much better, much more able to deal with a bigger procedure later on.
And what about creating ostomies preemptively? There's a lot of talk about these techniques to avoid a stoma, wherein when you have a rectal anastomosis, you don't have these crossing sutures, put another layer of sutures around it. But my concern is with this extensive disease, when there's high volume ascites, you have 2 bowel anastomosis, or even one rectal anastomosis. I would be far more comfortable creating a stoma and reversing it later than, especially when there's high volume disease. In the ovaries, we do it all the time, but what about PMP, and what is your policy of creating stomas?
I'd agree. I think we probably we're maybe doing a little less. We're bringing out a little less stomas than we did before, but we're still very low threshold. So we've got a low rectal anastomosis. I think will almost invariably defunction. If it's a mid to upper rectal anastomosis, then sometimes using the ICG to check for perfusion, a double layer, and then we'll take a chance. But I think if you've got more than one anastomosis, then if you've got an ileocolic and a colorectal anastomosis, which is low, then invariably we'll defunction that. It's just we don't, at the moment now, an anastomotic leak is a major disruption to what we do, because we're doing 8 or 9 cases a week. We can't really afford to have that type of disruption, because it impacts on ITU, impacts on everybody. So we'd much rather bring out the stoma. Obviously, ileostomies are not without risk, But for most people, and if you've got low-grade disease, you probably have it for no longer than 3 months. We'll bring them back fairly soon and reverse the stone.
Okay, thank you. There's one question from the audience. I don't know who the person is. What do you think about the role of immunotherapy in future of reducing managing recurrence? There is a study from Norway which found a strong link in GNAS mutations, and they have a trial too.
Yeah, I think it's
yeah.
really interesting, and I think that's Kirsty Flatmark's work with the GNAS T cell activation and then immunotherapy. I mean, I think we're a way off realizing that, but I think for patients with a GNAS mutation who have recurrent disease, then yeah, it may be really useful in stopping progression and avoiding further surgery, because even, I mean, Srikanth will talk about this, but even multivisceral transplant isn't the answer for everybody with recurrence. And it's a major undertaking. But I think if we can prevent patients getting to that point, then yeah, I mean, I've been talking to Kirsty about identifying a cohort of patients that have recurrence who have the GNAS mutation that would be suitable for a trial, phase 2 trial or a phase 3 trial. But she's doing the phase 1 stuff now, I think. She's got some funding for that.
Thank you. Dr. Rohin, do you have any further questions? Would you like to close the session? You are muted.
Thank you. Can you hear me now? I think you can.
Yep.
Yeah. Thanks, Faiz, for the excellent presentation. I think a lot of good points and a lot of experience in those slides, especially involvement of other people and the teamwork, which I have seen, and obviously is reflection of the work that you do. So thanks again. I think we'll close this session now and we'll go on to the next stop. Back to you, Elise.
Thank you.
Thank you, Dr. Faiz. Dr. Ramakrishnan, you'll take over for the next session.
I hope the issue with the security is sorted out, and we have Dr. Srikanth's slides with us.
Yeah. Kalpesh, will you share the slides? Yeah. Okay.
All right.
Yeah. Can you hear me now?
Yes, we can.
Yeah, I'm going to talk a little bit about intestinal transplantation and also about our experience in working with the Basingstoke team in offering transplantation for a small number of patients. Next slide. I think it was first attempted in 1964, but I think for almost 3 decades there were no successes. But finally, I think David Grant, a surgeon from Toronto, published a small series of successful transplants. And after that, I think it's carried on, and I think it has never been done in high volumes. Currently, between 100 to 200 cases are being done worldwide 1 year. You got to put that in the context that they're doing more than 200 cases a year for pseudomyxoma just in Basingstoke. For some reason, the photos are not coming up, but I think we might have to just accept it. Intestinal transplantation, why we do it, means just go to the next slide, please. Next slide. So I think what is it that makes it more challenging than other organs? For example, kidney transplantation is routine now. Many thousands are done in UK and worldwide. Most patients go home within 5 days. With intestinal transplant, the bowel comes with a high immune load, and that poses a number of challenges. Of course, the gut also carries a huge, not a burden, a huge load of bacteria, and this operations can be very difficult. And we also struggle with infections such as CMV and renal toxicity. Of course, like we discussed with peritoneal malignancy, you're constantly trying to, of course, find solutions to the problems. by modifying immunosuppression, using different kinds of intestinal grafts, and using different techniques for abdominal closure. Next slide, please. Next slide. Is there any reason why we're not getting photos? Means I'm not sure why. Means Aditi, means is there any reason why the photos are not coming up? Do you know why?
Do we have an answer to that?
Sorry?
No, I'm just asking the host.
Yes, ma'am, I'm doing it. Give me a time.
Okay.
Just a minute.
Okay.
Are we back to the presentation, Aditi, or I can just only, I can't see it.
No, he's just trying to short.
Yes,
Can we not put it on the slideshow? I think this works
it's
better.
working now.
Yeah.
It's working now.
Yeah, so I think this is what we are here. I mean, some of the surgery can be very radical. Yeah, next slide, please. Next slide. So there are a variety of indications for intestinal transplantation. Of course, I have summarized the accepted ones. One is if you've got intestinal failure. TPN facilities certainly in a number of developed countries are pretty good. Certainly in UK, the majority of the patients who got intestinal failure due to conditions such as Crohn's disease, or if you lost cut due to vascular complications, they can be maintained perfectly well with parenteral nutrition long term. But a small number of patients do develop life-threatening complications, and of course the two serious ones are intestinal failure associated liver disease, and the second thing is thrombosis or sepsis related to central venous catheter. If either of them are happening, then of course these are the patients who could potentially benefit from intestinal transplant. And locally advanced unresectable tumors such as desmoid tumors, and a small number of patients with neuroendocrine tumors, and pseudomyxoma falls in this category, also could potentially benefit from intestinal transplantation. And there are a small number of patients with intestinal failure who have got very poor quality of life, and they accept the risks and they proceed to transplantation. Next slide, please. I think, so this is summarizing that the indications are slightly different in pediatric patients, where you got things like gastroschisis and volvulus, etc., which come into play, compared to adults. Next slide, please. In adults, of course, you see other indications such as Crohn's and ischemia. Next slide, please. So there are different types of grafts. I don't know whether you've seen this from one of the Basingstoke team. You can get what is called a full multivisceral transplant, where you transplant the liver and all the abdominal organs apart from the kidneys. Or you can just have an isolated small bowel transplant, where you transplant the small bowel. But we also transplant the small bowel along with colon generally wherever we can. And there are some patients where it's in between, where you don't need the liver, but you might also have to transplant the stomach with the pancreaticoduodenal complex. Next slide, please. So this is an isolated photograph of an isolated small bowel transplant, and that's where a full multivisceral graft, where there's a liver with the small bowel also that has been transplanted. Next slide, please. The abdominal wall reconstruction can be a challenge, especially, as you know, because I think the whole group is surgeons. If you leave the abdomen open, the fascia retracts, and then often then it's difficult to get back the domain. It's the same here. Means the patients have lost the domain, or due to multiple previous abdominal operations, patients could have a very scarred abdomen. So you got to use a variety of techniques using, for example, here in this photograph, a biological mesh has been used to close the skin on top. Or in an extreme situation, we occasionally have to use a full thickness vascularized composite allotransplantation. Next slide, please. And of course, what we tell our patients is that it is not a cure. Means what you are exchanging is one set of problems. You got a TPN with central line and all the problems that go with TPN, such as liver disease, lung infections, thrombosis. And then patients have to take, even after a successful transplant, a number of medications to immunosuppression and other medications. Next slide, please. So how do we monitor the patient? One is how the patients are, like how we do with any other patient's well-being. If they have a stoma output. If there is no stoma, then how often they open their bowels. And sometimes you have to do an endoscopy and histology if you're suspecting rejection. If you're also having a high stoma output, you could send the effluent for infections. And the two infections that we worry about is CMV and Epstein-Barr virus. You can do, we request a PCR if that's a concern. And where we are worried about graft versus host disease, we might do a peripheral chimerism. Next slide, please. So the outcomes are certainly not as good as for peritoneal malignancy surgery, but actually better than, I'm also a liver and pancreatic cancer surgeon, better than certainly pancreatic cancer surgery or liver cancer surgery, the 5-year survival and the 10-year survival. So it's hard work, but actually the outcomes are reasonably good compared to a lot of major cancer surgery. Next slide, please. And the results have got better with time. And this is Pittsburgh has done the most number of transplants for intestinal transplants, and they've shown that actually the results do improve with time. And we briefly touched about the learning curve and experience in the previous talk, and that's reflected in the slide. Next slide, please. And of course, over a period of time, we have got better in patient selection, and of course, you learn more about surgical technique and immunosuppression. And results have got better with time now, such that we can hope for a 50% survival at 10 years. Next slide, please. And this is again a slide from Pittsburgh, where they published their experience in Annals of Surgery, and where they showed that actually most patients have nutritional autonomy. We're not able to replicate that with pseudomyxoma patients, and they got very good long-term outcomes. Next slide, please. So if you suspect rejection, then rejection is a common problem. You do endoscopy, and you can also do what is called zoom endoscopy, where you can look for villi if you have the facilities. And then you do a biopsy and you try to distinguish between rejection or infection. Next slide, please. Next slide. I think we can skip this. This is a patient where there's moderate rejection. For those of you who do endoscopy, you can see ulceration in the small bowel. Next slide, please. Or severe rejection where you lost all the villi and you got the mucosa that is sloughed off. Next slide, please. And you can also get infections. Means the CMV is the one that is the most troublesome. So that's why you need to be able to distinguish between an infection and a rejection, because for rejection, you're going to escalate the immunosuppression, whereas for infection, you're trying to reduce the immunosuppression. So you need a good multidisciplinary team. You need an experienced endoscopist. You need a pathologist. You need your ID lab to be able to do the blood samples for CMV and PC and the EBV PCR. Next slide, please. You can also get cancers. They happen sadly in more than 10% of the patients, which are driven by immunosuppression. Epstein-Barr virus is the one that drives a lymphoma called post-transplant lymphoma in these patients. Next slide, please. And sadly, approximately 10% of the patients also get what is called graft versus host disease. As you know, the gut has got almost as much lymphoid load as the bone marrow, and we have actually lost patients due to bad graft versus host disease. Next slide, please. This is just it can present with the rash. And in extreme situation, you can get a wipe out of the bone marrow. Next slide, please. So these are the complications which are summarized. Kidney failure happens in 1 in 5 patients at 5 years because of side effects of tacrolimus. Lymphomas happen in 1 in 10 patients at 5 years. So a significant burden. And infections, the common ones are cytomegalovirus, Epstein-Barr virus, and herpes. Next slide, please. So this slide, I think we can skip because all of you know more about it than myself. Means next slide, please. So next slide means again we can skip this. These are the slides that I think Tom Cecil has kindly shared from Basingstoke, where showing that you get very good outcomes. Next slide, please. And you heard from, I think, the talks earlier, I missed some of them, that a third of the patients get a recurrence. And when you get a recurrence, only a third of them are operable. And 2/3 are not operable. And of course, even when you debulk again, some of them get recurrence. So there are a proportion of patients with pseudomyxoma where you can't do conventional surgery, either and fistulae and fungating tumors. And unlike some of the other cancers, such as pancreatic cancer or liver cancer, where the disease course is more rapid and patients die more quickly, here in some patients, they can have an indolent disease where they have a limited life expectancy, but they also have poor quality of life towards the end. Next slide, please. This is again a slide that Tom has shared of patient with bad fungation and fistulation following recurrent pseudomyxoma. Next slide, please. And there's only one, I think, publication on life expectancy. If you got, of course, high-grade disease, when you require parenteral nutrition, the life expectancy is measured in months rather than years. If you got significant obstruction such that actually you're reliant on parenteral nutrition, you got a very short life expectancy at that stage. Next slide, please. This is again experience of in Basingstoke for patients who actually ended up on parenteral nutrition. And next slide, please. So, sorry, can we go back to the previous slide? So here it shows that actually if you have a high-grade disease, generally by the time you get high-grade bowel obstruction such that you're contemplating parenteral nutrition, your life expectancy is actually measured in weeks. Whereas if you've got low-grade disease, you can carry on for almost a year, means 10 months. So you got time to make the decisions. And of course, the patients where the disease is running away, you know that actually further surgery is futile. Whereas the patients population that we are looking at is the patient population where the next slide, please. Where what we're trying to do is select patients with biologically favorable disease. That's either low-grade disease or slow growing, where it's indolent, which is carrying on over years. And of course, we got the Fahiz, Sanjeev, and of course the other surgeons, senior surgeons from Basingstoke, looking at the scans, looking at the patient, and saying that there are no further options of cytoreduction. And patients are getting bowel obstruction, either they're already on parenteral nutrition, or you're thinking that they might end up on parenteral nutrition in the near future. And in the best, of course, as you all know, as cancer surgeons, that actually predicting what happens to a single patient is the hardest thing. When the families ask, or the patients ask us question, how long I got, your answer is actually, I don't know for certain. So here you're trying to make and it's same here, you're trying to make a best guess that actually your life expectancy of the patient is likely to be in the order of 6 to 12 months. But you got to accept that, acknowledge that actually it's not a, even in cancer types where we're looked after tens of thousands of patients, is you can't be sure about an individual patient. Here it's even more harder when you got a rare disease like pseudomyxoma. Next slide, please. So we have formally assessed over 30 patients here in Oxford. So we've transplanted 15 patients, and one of them we've opened up with a view to transplantation, but we managed to free up 200 centimeters of the bowel and avoid a transplant. And the other patients either were unfit for transplant because they got unfit during assessment. Some were waitlisted and died on the waiting list. And there's one patient who has been taken off the waiting list and debulked. So we discussed many more patients but with the team in Basingstoke and the team up north in Christie's Hospital. Next slide, please. So this was driven by a patient called Stephen Prescott. He wrote a book, so we're not breaking any confidentiality. It's actually a patient saying that, look, I got recurrent pseudomyxoma. They can't operate again in Basingstoke. Can you remove all this and transplant new bowel? So sometimes patients, Stephen Prescott is one of those inspiring patients and people who actually has pushed the medical team to actually take on a new indication for intestinal transplantation. Next slide, please. And this is, of course, done. We are fortunate that in Oxford, we are only an hour away from Basingstoke. I don't think it would have been possible if we're not that close as teams. Next slide, please. And in Oxford, initially, when the program was being set up, this is Professor Friend, who is actually quite a well-known and famous, internationally famous transplant surgeon. And Anil Vaidya, who was one of our transplant surgeons. He worked in India for a few years, now has gone to Cleveland Clinic. They were instrumental in setting up the program and doing the first case. Next slide, please. And Hank Gill is one of our plastic surgeons, again a very talented surgeon of international repute, and he helps us with abdominal wall reconstruction at the end of the transplant. But what we realized over a period of time is that majority of them don't need a formal abdominal wall transplant. We can get away by just using a non-vascularized fascia. Next slide, please. So I think you've seen this slide. I think the goal of the surgery is to remove the debulk and remove all the disease, at least the visible bowel. You can aim for complete cytoreduction, but it's not possible in majority of the patients. And even for surgeons who are as experienced as Fahiz, it's actually difficult to tell between scarring and residual disease. Means I've been involved only in the operations that are being done in Oxford because we don't have a peritoneal malignancy center here in Oxford. So it can be difficult even for very experienced surgeons to tell the difference. Next slide, please. We always have a modified multivisceral graft available for transplant because it's impossible to tell before the surgery whether you can get away just using an isolated small bowel or whether actually the stomach and the pancreaticoduodenal complex also have to be replaced. So we always have a modified multivisceral graft available. Next slide, please. And then this is where I think showing a small bowel graft and closing with an abdominal wall graft. But now off late in the last few patients, actually we stopped. We rarely need an abdominal wall transplant in these patients. Next slide, please. So this is the patient demographics. We transplanted 15 patients. You're choosing young and fit patients. Of course, I wouldn't go beyond 60 because patients had to go through a lot, and more male patients. Majority of the patients with high-grade disease, though we've done one patient with, majority of the patients with low-grade disease. We've done one patient with high-grade disease a couple of years ago who's doing well. Though the histology was high-grade, I think the disease course was indolent, and the Basingstoke team felt that it was reasonable to transplant that patient. As you can see, that half the patients require the stomach and the pancreaticodental complex also to be replaced. But we found that actually you can get away in half the patients using a small bowel graft. You try to, cold ischemia is the time where the organs spend on ice after procurement in the donor and transplanting into the recipient. You try to keep it as short as you can. And the hospital stay is more than 6 weeks. Next slide, please. This is our experience with the initial lot of patients. You can see that actually the operations can be long, means they can often take between 12 to 18 hours. And the blood transfusion requirement has got better as we've done more cases. But typically patients require 5 to 6 units of blood transfusion. And they also end up requiring FFP and platelets. Next slide, please. And again here, this is with the first few patients showing that there's again a learning curve. The first and the third patient sadly didn't leave the hospital. But since then, all the patients have been successfully discharged following transplantation. So there is certainly a learning curve. Even for, so we got a very experienced cytoreduction team from Basingstoke. We have a very experienced transplant team from Oxford. Even then, it's a big undertaking. So you need a very strong multidisciplinary team to be able to take on something that is as formidable as this. Next slide, please. Next slide. I think we can skip this. And this is the long-term outcome in the patients. Next slide, please. So 9 out of the 15 patients are still alive. Means all the patients were discharged on eating and drinking. A third of the patients have got rejection and require treatment. And 6 patients have died due to a variety of causes. The first patient died on day 29 due to anastomotic leak of the esophageal anastomosis and chest sepsis. The third patient had a biliary leak, was festering in the hospital, but was getting better. And then sadly had a GI bleed died from an old-fashioned gastric ulcer. One patient, a young lady who's doing really well, died due to graft versus host disease and bone marrow failure at 6 months. There's another patient who actually, I think the patient was never 100% debulked. After a progression of disease, died 3.5 years down the line. There's another patient who died due to a cancer at 3 years. And one patient who actually chose to, actually opted for palliative care at 3 years because had multiple problems, had an intracutaneous fistula, kidney failure, poor quality of life, and then said, look, I've had it, and then actually opted for all medical care to be withdrawn. So patients have died due to not a single cause, due to multiple different causes. And what is interesting is only one patient has died due to recurrent disease at 3.5 years, though there are a couple of long-term survivors who are getting into trouble due to recurrence. Next slide, please. So 5-year survival is approaching 50%. So as we discussed, 1-year survival of 85%, 3-year 75%, and 5-year approaching 50%. So it's certainly better than what you get for pancreatic cancer surgery. But perhaps not as good as for breast cancer at 5 years. Next slide, please. Sadly, we're not able to get the same level of, okay, this is the graft survival. Next slide, please. Can you go back to the previous slide? We're not able to get the same level of nutritional autonomy. Most of the patients, almost half the patients require TPN long-term because they got one problem or other because of variety of reasons. But we're hoping this can improve with time as we get more experience. Next slide, please. So this is a more focused slide showing that actually we're hitting 50% 5-year survival. Next slide, please. This is an example of where you got the jelly in the abdomen, and of course, cytoreduction with the new organs 6 months down the line. Next slide, please. And this is a patient again who is now back to work, working as a tree surgeon and having a good quality of life. Next slide, please. We also captured quality of life, formal quality of life data in the patients, showing that the quality of life improves. Next slide, please. The domain that's fine, you carry on. The domain that is the improvement is the most in is the pain, because the patients that you select, they have large tumors, they're bulky, a lot of them are requiring morphine and other opiates. And the pain is one factor that gets better after transplantation. Next slide, please. Next slide, Mensa. But now, as we are following them up further, we have found that actually all of them have recurrences. This is a patient who has got a recurrence in the abdominal wall next to the sternum. This is a patient who has got a recurrence in the spine. So now we tell the patients it's not a cure. All the patients are going to get some sort of recurrence in time. And so, next slide, please. So our psychologist has provided the slide. So she has seen the patients. And even after transplantation, a number of them have got low mood, a post-traumatic stress disorder-like situation. And one patient has died after refusing ongoing treatment because has been tired and exhausted and actually had achieved what he wanted. And none of the patients we have selected had a significant history of mental health problems in the past. Next slide, please. This is again a slide provided by the psychologist giving patients comments. Next slide, please. And again, this is a slide from our gastroenterologist showing that actually transplanting when they're nutritionally fitter is better. And that's not surprising. If you choose patients who are fitter, they do better after major surgery. So next slide, please. So what are the lessons learned? It's feasible, and highly selected patients could benefit from transplantation. It's a timely operation, which is the biggest challenge. If you transplant too early and if they have major complication, then you regret thinking that, okay, have I brought the patient to harm? And as you know, as doctors, our oath is first do no harm. On the other hand, you wait too long, and then they have either higher complication rate, or generally the working rule transplant when patients are parenteral nutrition. When you think that they're going to require parenteral nutrition, that's when you should be thinking about a transplantation. And I think this is the most crucial thing. You need a very experienced pseudomyxoma team and surgeons who are really super experienced and top of their game, and also an experienced transplant team. Sorry, previous slide, please. And also, we had to aim for complete cytoreduction if we can. Next slide, please. And we are trying to introduce prehabilitation for our intestinal transplant patients. It's much harder, as I hear what Faiz is saying. If you've got a large tumor and patients are finding it difficult to get around, it is hard. I mean, cycling is very popular in UK. Certainly among the medical staff, surgeons and anesthetists, we encourage patients to get fit, and using a power breather to get fit is something that is we try to aim for, but it's not always possible. Next slide, please. So what about the future patient selection? Means can we put the patients forward for transplantation earlier? Can we select the patients with high-grade disease? Are tumor markers going to be helpful? And if you can certainly improve the 5-year survival, then we can justify transplanting patients earlier. And of course, can we get a matched control group where we can see where we can evaluate in a more scholarly manner what is the true benefit of transplantation? I don't think we're ever going to get a randomized control trial, but as we do more, then we got to then see whether we can actually try to pull out match controls and see how much benefit with transplant is present. Next slide, please. And of course, if we can get immune tolerance, parenteral nutrition was initially developed and invented by surgeons. Stanley Dredrick was one of the surgical residents who actually was the first one to demonstrate its feasibility in dogs, where he kept puppies alive for a year on pure parenteral nutrition. And of course, if you can transplant patients by minimizing or without rejection and immunosuppression, then you can transplant a lot more patients. And Peter Medaver I think he also worked in Oxford, was a famous immunologist who actually showed tolerance and is considered one of the pioneers in transplantation and won a Nobel Prize. So I think if we can actually minimize immunosuppression with cell therapies and other advances that are coming on, some of which we are fortunate to take part here in Oxford, then you could perhaps consider transplanting more patients and also transplanting more patients for cancers like pseudomyxoma. Next slide, please. So in terms of conclusion, I think what we can be proud of, certainly both the Basingstoke and Oxford team, is that actually it's something we've done for the first time in the world, so a world first. 5-year survival is comparable to or better than outcomes for some major cancer surgeries such as pancreatic cancer. We are trying to work on increased and early referrals. We've set up virtual clinics with Basingstoke, and we're also trying to set up one with Christie's. It's not a cure. All the patients have a recurrence. Exact time is a challenge. Exact timing is a challenge. I think it's always difficult to get it right. But we'll lead close discussion with PMP team, and as we get more experience, perhaps we'll get better at patient selection and timing of transplantation. Another thing we shouldn't forget is you have to have an access to a pool of deceased donors, and I think it's going to be a big challenge in India, where we know deceased donor transplantation is not as well developed. So I think that's the last slide. Thank you. Yeah.
Thank you, Dr. Srikanth. Very excellent presentation, and congratulations to your team at Oxford, who have, in collaboration with the Basingstoke team, actually pushed the envelope in terms of improving outcomes and offering at least a glimmer of hope for patients who have such advanced tumors. But at the same time, it is quite disheartening to see a slide where you mentioned that there is a nearly 100% recurrence rates even after a small bowel or a multivisceral transplant. I noticed in one of your slides that you had mentioned that cytoreduction was not complete in at least 3 or 4 of the patients. So do you still perform a transplant even if the cytoreduction is not complete? And how does that affect the outcomes of the overall survival of the patient and the recurrence rates?
I think that, of course, the numbers are very small. The problem is sometimes you're into such a mess you can't get out. There's one patient. I think the other thing you should note is we haven't done any liver grafts because in UK access to liver grafts is more restricted. There are a lot more patients who could benefit from liver transplantation and are not listed. So you got to be confidently have more than 50% 5-year survival. So we won't have access to liver grafts in this country, certainly not in the near future, unless we demonstrate even better results. I think there's a situation where you come in, you are actually got into multiple enterotomies, you also actually opened up the stomach, and you got no other option at that stage that actually the only way we can get the patient off the table and get the patient out of the hospital is by doing a transplant. That's in the first few patients, though we did 2-3 years ago, we had a patient where I did with Tom. You think, okay, are we going to kill this patient on the table when you're in the porta hepatis? So I think at that stage, I think it's too late to pull out. And I think that's the situation we're talking about. Yeah. Okay. So we have gone and transplanted them because it's too late to pull out. The patient, the second patient who survived actually had a very good quality of life for 3 years. When she even did a video, a BBC presentation, and there's a documentary on her, I haven't shown it, where she actually had 3 good years of quality of life with the family and the patient, with the family. So, and she eventually died. So while it's disheartening, I think for a number of patients, it has been life-changing. And it's like, I think how patients with cancer, like pancreatic cancer, have an operation because there is hope. And some do well. A lot of them don't do well. That's a sad reality. But both the patients try, and we as the clinicians also try on their behalf. But as we get more experience, I think hopefully the results will get better.
Yeah, surely these are early days, and I think as we go along, things are going to improve.
And I think the thing is, there are two aspects to the whole process. One is the cytoreduction, of course, that's where the Basingstoke team come in and we operate on them jointly with them leading on the case. The second is, it's a rare indication. You need more fundamental advances in transplantation, like where, of course, we do 300 transplants a year. We got a huge interest in cell therapy with some world-leading experts leading science on it. So what you need to do is plug in other advances that come in immunosuppression and other things, and then apply them. We're not going to be able to develop immunosuppression advances based on intestinal transplantation because it's a small number. We do 5 or 6 a year. I think hopefully as further advances come in transplantation, mainly driven by kidney and liver, some of the benefits from there can be actually applied to the intestinal transplant patients. So these are such rare operations. When patients ask me, how do you train yourself to be an intestinal transplant surgeon? The first one I did on my own, having never done one before under supervision. You just put all the other skills as a general surgeon, cancer surgeon, vascular surgeon, transplant surgeon. You put all the skills that you have and you practice into this one operation, which you do very infrequently. That's the bottom line. Yeah. I think the last one Faiz and I did in the middle of the night a month ago. So that's where you put all your skills, your resilience and everything in one case. I think that's the case here going forwards.
I think it's good to have different skill sets, isn't it, Srikanth? Because when I operate with you, I feel emboldened because I know if I make a hole in an artery or vein, you'll sort it out. Yeah. So I think there's a great benefit from having that cross speciality.
Yeah. Certainly. Yeah, you're absolutely right, Faiz. I don't think we would ever embark on this transplant without having one of your teams physically in theater leading on the cytoreduction case. Yeah.
So where exactly have these patients failed? In the peritoneum, I saw one of your patients had a spinal mets, but is that, is the recurrence usually intraperitoneal or is it extraperitoneal?
It's all of them have intraperitoneal, but that patient, I'm just showing that the patient who has a recurrence, recurred almost 2.5 years ago and has survived 5 years, has got this. It's just because the PET scan is more visually appealing. That's why I put the picture up. It's not that he's one off actually. So he's got a recurrence with very large lymph nodes, a spine met, and also lung mets actually. The others have all been actually peritoneal.
So have these peritoneal recurrences been salvaged?
Salvage means, yes, means one patient we reoperated and took out that abdominal lump. There's a second patient we just did a laparotomy 3 weeks ago and is getting better. But the problem is actually it can be I think one of my perforated had a lot of adhesions, so obviously we're reluctant. But we have salvaged one patient recently. The answer is yes. I think as we do more and we have a bigger cohort of patients, we will look at, is it possible to salvage these patients on a case-by-case basis? That's going to be the plan going forwards.
Aditi, you had something.
Yeah. So that's a very inspiring talk and a very inspiring program always. And I had a few questions. One is that you've been discussing about the timing of transplant. There are patients who are not on TPN, but you know that they are going to get on to TPN. So wouldn't that be a better time to transplant them? Because do you really want to wait for the disease to grow so much that the patient's on TPN? You know, there's grossly inoperable disease. So
I think
what
you're right. If we had a crystal ball is where you can look into the future, then that is the best time to do it before patients require TPN. But as you know, that's what medicine is, an art and not mathematics. No? So we need people, Fahiz and his team, to get very good at that art, no? And then they can refer the patients at the right time, and we transplant them just before the day they need a TPN. Yeah, I agree with that. I agree. Yeah.
I mean, you're right, Aditi, but it's very, some of those patients will actually go on for a number of years before the point of needing TPN. So it's difficult to predict. And then, you know, if they have problems from their transplant or from their transplant, you've essentially disadvantaged them. So it's really tricky. You're right, because we do sometimes miss the boat. And with COVID, we had one patient who was due to have a transplant. COVID stopped everything. And then, you know, he deteriorated. Interestingly, he had a lung met from low-grade pseudomyxoma, which was removed. And then we thought, he was on home TPN, but then he went on to home TPN. We ended up having to operate him on him again in Basingstoke before he got to a transplant, and he kind of deteriorated and missed the boat. So it's not easy.
And what about involvement of the urinary tract? You know, some of these patients have bladder involvement, ureteric involvement. What about those patients? And the second question is, what about patients with retroperitoneal tumor implantation? A lot of times patients have had surgery by surgeons who are not adept at peritonectomies, and there's a lot of involvement of the retroperitoneum. Like there's psoas muscle infiltration. To me, such patients will have a 200% chance of recurrence. So do you consider these factors while selecting patients for transplant? Like, you know, it's not just the organs that you're going to transplant. You could plug in the ureters and create a stoma.
Means I can let Fahiz add it. Means, of course, ureters is something we always worry about, and we stent the patients at the beginning. The first step of the operation is stenting the ureters so that you can feel them. But it's a challenge, and almost all of them require high Tom, means a bit of bladder removed. And the second thing is, the last patient that we did just 3 weeks ago, we had to leave a tiny sliver of disease between the right ureter and the bladder because you didn't want to actually damage the ureter. So it's a challenge. Means psoas, etc. Of course, you can remove it, but the ureters is obviously a challenge. And there's one patient who ended up with a ureteric stricture, and actually we a few years before, which required actually a nephrostomy long term. So you're right. Means I think it's a challenge, and that's where you need teams taking on the challenge. Faiz, do you want to add to that? Means, of course.
Yeah, I mean, I was talking to Tom about this the other day, because once you strip when you do a pelvic peritonectomy, you strip the peritoneum from the bladder. When you get recurrence, you invariably get involvement and infiltration of the bladder, and that's a really difficult thing to manage, and patients get incredibly symptomatic from it. And so even if you can clear the disease from everywhere else, they get these awful urinary symptoms. So I guess the next step would be to consider a cystectomy and then a urostomy or a wet colostomy. We haven't done it yet, but it would be the next step, I guess, to manage those symptoms, because that is a problem.
So if I understand correctly, you know, the patients who would require transplantation of the liver were excluded. So you would have a lot more patients if you were able to transplant liver easily in this. And
I guess, you know, once we've stripped the right diaphragm, often the right diaphragm just sticks onto the liver. So usual to get recurrence over the surface of the liver, but obviously you can get disease around the porta, and that's a problem, because if we strip the porta before, you know, the patients where we haven't gone to the porta and or if they've not had any previous attempt at cytoreduction, actually that's much easier to deal with. And our longest survivor from transplant didn't have a traditional cytoreduction to start with, basically just had a venting gastrostomy, and then their first procedure was a transplant, and that made it a lot less technically challenging, because it's that porta, and I think that's where we all get into trouble if it's been stripped. If you've stripped the hepatoduodenal ligament before, then that becomes quite treacherous. So I guess, yeah, I mean, at the moment now, if we can, it is the timing of the patients, and also perhaps preempting patients that might go onto a transplant. So if we're doing a debulking, rather than doing a maximal tumor debulking, we do a selective tumor debulking, where we say, well, actually, this person's young and fit. We're not going to be able to remove all the disease. Perhaps we should just back off, get them out of trouble, and they may be a candidate for a transplant in the future. And if it's just small bowel, then that's the easiest. When I say easiest, it's certainly less technically challenging than pancreas, stomach, and everything else. Then we may be able to preempt those technical difficulties and just think one step ahead, and just back off, and maybe not strip the, don't strip the porta, or don't do anything more. They just do not touch the upper abdomen. And often if we're doing a debulking, we won't touch the upper abdomen. It's those patients who we've done a complete cytoreduction on who then recur. That's the challenge with the bladder, with the liver, with all of these things.
There is a question in the chat box. How is the availability of the transplant managed?
So, sorry, can you...
Yes,
availability of...
The question, how is the availability of the transplant managed? Because I assume that these are all strictly planned and based on the availability of the donor, isn't it?
Yeah, it is. There's a well-established framework for organ transplantation in UK, which you tap into, where, like, similar to how you go for a kidney or a liver transplant waiting list, you go on a waiting list. And if a donor comes up anywhere in the country, then there's a centralized computer system where, depending on where you stand in the waiting list, if the organ is matched to the patient, then the patient is called in, and there's a separate. So then the transplant would go ahead, and we would normally give Fahiz or Tom a heads up when the patient is going to the anesthetic room. So you know, and an experienced surgeon would go out and inspect the organs to make sure they're suitable for transplantation. And then they give us a shout saying that it looks fine, you can start your operation. Yeah. You're reliant on availability of the graft, so it is unpredictable, often in the middle of the night. Yeah.
So you did mention there was the average waiting period. Was what, 6 months, was it?
The average waiting time for small bowel transplant in Oxford is 4 months. It is, but probably for pseudomyxoma patients it is shorter because they're not going to live that long actually. So they come off the waiting list, they deteriorate or die. For the overall waiting time for intestinal transplant in Oxford is 4 months.
Dr. Deepti, you raised your hand. Please ask your question.
So what is the minimal length of the bowel you select for the transplant? Is there any criteria like that?
No, we use the whole of the small bowel, isn't it? As in the length of the small bowel varies anywhere between 4 to 6 meters in an adult. And we also use the right colon because the blood supply from the right colon can be pulled off the same superior mesenteric vessels. Yeah.
Any other questions?
So do you take requests of patients from outside of the UK? I guess they cannot be eligible for cadaveric transplant in the UK, which is,
yeah, it is a challenge though. No, I don't think we'll be able to, because you can use the organs only if they're not eligible for UK, and previously when UK was a part of EU citizens. But no, means if it's purely isolated small bowel for indications, because there are not that many UK patients waiting for a transplant, we have transplanted patients from Mexico and abroad for purely isolated small bowel, where we know the pancreas and the stomach is not required. But here, you wouldn't start the operation without knowing that the pancreas and the stomach are also available. And that almost certainly, because you choose perfect donors, almost certainly that organ could have gone to somebody else requiring a pancreas transplant in UK. So you're absolutely right. It's unlikely we'll be able to offer this to non-UK citizens.
So, Faiz, if I may ask, what situation would prompt you to decide that this patient requires a pancreatic transplant? Is it extensive disease surrounding the pancreas, or is it for the ease of doing the transplant? I mean, what is the technical aspect behind that?
Yeah, I mean, I think it may be a bit of both, but I think, yeah, no, if the disease is involving the pancreas, and not, it isn't always, but if it's the surface and the whole pancreas is involved, then yeah, then that's when we would, because it does add, technically to the procedure. And I think if we can, I mean, the last one that we did, Srikanth and I did, was just small bowel, and that was, I think it took us about 5 hours to do the explant, and then probably took another 4 or 5 hours, Srikanth, for you to do the transplant.
Yeah, and also abdominal wall closure was difficult, and then we had to get the pressure from the donor. Skin was there, and we closed the bridge, the defect with the fascia, and then closed the skin. Yeah.
Any other comments or questions? I guess there are none. Thank you once again, Dr. Srikanth, for a very informative lecture. Thank you. Over to you, Aditi.
Yeah. So I think it's time to wrap up, and we have a very clear message from this webinar. PMP requires a specialized and dedicated effort, and we hope at least a few such centers will come up in India, because we have a huge volume of patients. And thanks a lot to all the participants, all the panelists and the faculty, and thank you to all our speakers, especially Dr. Faiz, Dr. Sanjeev, Dr. Reddy. Thanks a lot for sparing so much time. And it was an excellent session, and hope to see you soon again, virtually or in person.
Definitely in person.